I'd like to invite up our first brave soul, Mr. Jeff Lawrence. He's got a unique presentation in store for us about how Spectrum Health uses predictive alerts and real-time info to improve outcomes. Jeff is responsible for assessing business strategy and technology trends, as well as organizational capability, and is a core team member of the enterprise architecture team at Spectrum Health. Please put your hands together and welcome Jeff Lawrence.
Cool. I think we're supposed to start with the video, maybe? Yes? Video? I'll stand here and look cool while the video plays. Today, we're going to talk about bedside clinical technology and its relationship with real-time health. Are we on the right path to be the leader in clinical bedside technology by 2020? In the late 1800s, Florence Nightingale introduced the world to the concept of knowing. Colleagues of Florence identified her skill in nursing to be so advanced she could predictively treat patients based on knowing what procedures will lead to the most positive outcomes. Florence published many papers on this concept, how to recognize knowing patterns for everything from environmental factors, the weather, and even who the patient had been in contact with. Today's concept of knowing is basically the same, although a little more advanced. The concept of knowing today introduces a wide breadth of technology solutions to assist in knowing what is happening with the patient. Medical devices, such as patient monitors and ventilators, have their data aggregated and directly integrated with our EMR. Clinicians carry mobile devices that allow real-time communication with each other. Content is streamed directly to the patient, customized based on their condition. Clinicians are provided more efficient mechanisms to access clinical systems with virtual workstations. Clinical alerts bring clinicians together when immediate assistance is required. Real-time tracking is becoming more and more prevalent in the healthcare system, providing clinicians with the capability to know where their patient is inside and outside of the hospital. In some cases, video solutions are enabling patients to reach their caregivers directly from any location. Knowing today is real-time awareness. Reaching this level of knowing today, however, has come at a cost. While these services are provided, we tend to build them in silos. These technology silos rarely interact with each other without investing time and resources into building integration between them. Sort of like moving material between real silos with tractors, except in our case, we move technology and resources. Approaching technology like this has its pros. We can be agile on building new silos and worry about integrating after they are built, using our technology tractors to bridge the gaps. One trend we have noticed with this approach is that our clinicians become subject to something a little different than the expected outcomes the silos claim to offer. Hospitalists using our mobile services, for instance, end up carrying various devices to accommodate all the use cases. In a real-world example, they carry multiple pagers, ASCOM phones, clinical devices, and even personal phones. So what if we approach these silos differently? What if we started with a platform and only purchased services that scale vertically and allowed for interchangeable technologies? Investing in real-time health as a platform with the approach to build our solutions so they enable the platform could yield much different results. Silos can start to be eliminated, and the technical investments can be redirected to support the platform. As we grow into the platform, we can overlay communication tools, pull real-time analytics, and apply advanced algorithms to further enhance real-time awareness, and truly build on the knowing concept Florence outlined more than 100 years ago. What do you think about real-time health? Cool video? You guys like this? Okay, cool. Everyone's kind of looking at it, and I'm wondering, what's going on here? These guys, they like that, or? I think it's kind of funny. They asked me to come up here and talk about real-time health and predictive analytics, and I'm standing back there, and I'm waiting to come on stage, and they're like, yeah, Jeff, you're holding everybody up for breaks, so if you could just Yeah. And as I'm walking out, Siri's like, time to breathe. I'm like, no kidding, we're gonna come back to that. That actually fits. How interesting. A little bit about Spectrum Health. We have a pretty simple mission, and that's to improve the health of the communities we serve. We serve quite a few communities in West Michigan, and we continue to grow. When I drew this slide, it was 12 hospitals, and we just made an announcement. We're growing even more. We're up to 15 hospitals with 30,000 employees. We're a rather large enterprise, and we're also an organization with an insurance wing. And in our insurance wing, you can see some of the stats down there. We're providing to pretty much everybody in Michigan, and we're serving members across the United States with over 1 million members served. So you guys were introduced to Florence in the knowing concept in the video, and I think it's interesting, you know, some of the things that she thought about and how that worked. Obviously, she was an incredible nurse. I don't know if anyone has done any research on Florence or not, or knows, you know, sort of what Florence is about, but you know, the people, the environment, and the weather. I think we're going to come back to that as well, but it feeds into sort of what we're doing in 2018, right? Understand what we're doing with the health index, the EMR, and medical device information, and how we're interacting with that, and you know, the Muse scores and things like that. I think we need to really think about, you know, where that came from. So sorry, rambling a little bit. So I'm supposed to talk a little bit about Muse, and I kind of came up with my own definition of it because I kind of had to understand it a little bit myself. How many people actually know what Muse is and where it comes from? Quite a few people. Okay. For me, it was sort of identifying if a patient is deteriorating by abnormal vital signs and other clinical information. It's sort of information and an alert to give caregivers an opportunity to intervene to reverse the deterioration, quite frankly, right? And for the context of this conversation, I'm kind of summarizing with some vital signs. We're going to look at blood pressure, oxygen saturation, respiratory rate, heart rate, and temperature. And how does that actually work, and how are we calculating a Muse score? We kind of put these things on a matrix, and we assign numbers to them, and then we add these numbers up and give it a score, and that allows us to build business rules and processes around how we're going to respond to a specific score. So in this case, for patient John, his blood pressure is, let's say, 85. He's going to get a point, right? He's got a pretty normal respiratory rate of like 10. So we're not really going to give him a point that's pretty average. We're not going to go one way or another. His heart rate is a little high, like mine, right around 105. I'd probably get a couple points there. John's going to get a point, and he's pretty cool. He's a cool dude. He's 96.8, so he doesn't get a point there. And then his oxygen saturation is like way off. It's 84. So from a Muse calculation perspective, we add all these numbers up, 1 plus 0 plus 1 plus 0 plus 2, and John gets a 4. That essentially means John's going to need intervention, right? Something's going on with John based on this calculation. And that's sort of the basis for what builds a Muse score, and then we overlay algorithms for that. It doesn't come without challenges. You know, primarily, and when I round around the hospital and that sort of thing, prior to doing some of the real-time data feeds that I'm going to talk about in a second, nurses would do spot checks and take vital signs, and they would write them on napkins, right? And they'd be placing these napkins in their pockets, and they're doing multiple patients at a time. And you know, sometimes they'd print out these checklists, and sometimes the checklist didn't match what one unit had from another. And we had no medical device information coming into the EMR. And then in our particular case, we were actually a shop with 2 EMRs. We had Cerner and Epic in our environment, and they would be required to enter this information multiple times in multiple areas. So you can imagine, not only, it's not exactly real time, right? You're writing things down on a napkin, you're trying to come back later. The accuracy of that, I mean, like having multiple patients in your pocket and trying to discern which EMR you're going to enter in, that really adds a lot of problems to it. And on top of that, we had this process where our business support team would have access to our electronic medical record, and they would get a notification to say, hey, thanks for entering this information. It looks like there's a problem, an early warning score. Can you initiate a business process to contact somebody? And our business support team would pull up a different contact directory and send this one-way notification to a pager, in this particular example, physician on call. So there's just a tremendous amount of opportunity there. And we actually had some opportunity present itself at Spectrum Health. Part of this opportunity was around a few of our fearless leaders. They said, let's do a one EMR project. And it came with some strategic initiatives, right? Obviously, it was eliminating one of our EMRs. And I'm going to talk a little bit more about this, but not just eliminate the EMR, but look at the workflows behind it, the care flows, understanding how we're structuring this information. The second part of this, and this is really important, is the consolidation and normalization of medical device information, right? Looking at those different vital signs that I mentioned earlier, it was a huge project to do some data aggregation and pull all this information in, and I'm going to talk a little bit about what that experience was like as well. And then thirdly, as part of this one EMR project, we really wanted to focus on the next us collaboration, looking at the different types of devices that we're communicating with and how that relates to some of the business processes. Okay? Firstly, eliminating one of the EMRs. I mean, that sounds kind of easy. Like, don't document in two, just document in one. That actually gave us a ton of opportunity to look at how we're doing business, how the patient experience is being documented, and then how it's structured. We spent a tremendous amount of time looking at these encounters, looking at the technology underlining the process and what people we had assigned to it as well. So we really had an opportunity to take a step back and say, are we doing business correctly? Are we documenting the encounter correctly? And then, that kind of feeds into building an integrated patient record. Across the service lines with radiology, cardiology, lab, women's services, we wanted to have sort of that patient experience flow and have EMR-driven workflows across the service lines. We didn't want to have structured content out of the EMR. And I think that's really important because I'm going to talk about how we're doing the device aggregation here in a second, but think about that. And then obviously make this data available to act in real time, right? So the project to consolidate and normalize our medical device information. I have on here that this was so much fun. And our vendor that we chose to come in, I said, look, man, we're going to do a lot. And we have a lot of devices, and this is just an example of some of the things as we were mapping it out, but we're sending millions of lines of code into this system. I'm like, we're going to crush this thing, and the guy says, oh, no, you're going to totally be fine. We've done these institutions this size before. We blew this thing up, crushed it. So we had to scale this solution. If there's technical folks out there that want to have a conversation about how we're doing this, it's a pretty robust, large infrastructure. We still break it, but we're sending a lot of information through this gateway and into our EMR. Part of that project was sponsored from our associate CMIO group, and folks like informatics and informaticists and clinicians were sort of the chair and governance for understanding how and what data we wanted to bring in, and then building the structured content that I mentioned before in our EMR to match that. So the time commitment for this particular piece was pretty substantial, I think. I think, what would you say, like 40% of all of our work done revolved around medical device integration. Yeah, that was an interesting project. So then the next opportunity was sort of focusing on the next us collaboration, right? In our particular case, we do have communications systems in our environment. We have ASCOM. We have a little bit of Perfect Serve. We had a little bit of Vocera. We had a lot of different things. So we had a lot of different business rules and processes that were already sort of defined across the organization. The idea was to sort of standardize on these business processes. And we started by categorizing the types of information that we wanted to share and move around in our organization. And that was simply life-critical, informational, disaster, and emergent response. And life-critical were sort of those sepsis, the Muse alerts, those sorts of things. So we had some structure in there to work with. We continue to work with informational messaging, and the best way to do that. We have a pretty robust disaster notification business plan. And then we really need to work on emergent response. And I've had some conversations with some folks in here about how they're doing it. And I'd really like to have some more dialogue on that. So when we looked at those business rules, we said, okay, how are we implementing these with the different modalities, right? What do we tie clinical phones to? What do we tie pagers to? And then nurse call, how does that fit into these business processes, and are we building them correctly? And then ultimately, who and how do we send these types of communication to care teams, right? Specialists, technicians, nursing physicians, and our social teams. So when we built this, we actually built it with a one-way communication mindset, which is wrong, and that's something that we're working on. So when we put it all together from a Muse perspective, now we're doing device association. Our middleware allowed us to do that with our medical devices, and we're pulling in a tremendous amount of medical device information, as I mentioned. And we're having that real-time data feed go into structured content, and I can't express how important that is when you're building these things out. The structured content has to be structured and normalized in order for these algorithms to work. So we actually do a review from a Muse perspective with our business rules I think it's every 30 seconds to a minute, and we're looking at the data feeds that come in, and we have business rules set up to notify John's care team. What does that look like from Volt? Another thing that I found interesting about the conference is I was having conversations about middleware, and I'm not a huge middleware fan. I prefer direct integration with our endpoints. So I've been pushing Volt pretty hard on building a more robust relay for this sort of thing. And I found it interesting that a lot of folks here are pretty invested in middleware, and they've had really good experience with it. So it's kind of opened my mind a little bit on that. And I'd like to have more dialogue if you guys can find me after the session. I think that, from a technical perspective, I think I'd really like to understand that more. Simply put, from our Epic system, we're sending SMTP notifications. We're doing that through a relay, and we're sending that directly to the Iris server. And we're not crushing it today because we're, from a Volt implementation perspective, we have Volt in 2 of our hospitals. But I'm not sure this would scale to our 15 hospitals. So maybe a middleware play there is something we need to talk about, but that's sort of how that works today. What does it look like on the phone? So part of the configuration from Epic is sort of this global setting. You have to send notifications for all notifications a specific way, and one of their rules for their direct integration or their output is to not have PHI in the alerts. So this is sort of what it looks like. Actually, that's a screenshot of what it looks like. I didn't draw that part. And you can notice that it's pretty, there's not a lot going on there. There's some opportunity to do escalations. There's opportunity to have that bidirectional feedback. I'm going to talk a little bit about that in a second. But yeah, and it's kind of driven from the Epic business rules of not having PHI information. It is bad notification. You know there's an alert going on. And one other interesting thing about this is it's not role-based or it's not personalized. It's coming from the patient's chart, but we actually had to give it a specific extension, and then we route that extension into Volt. So it's not going to like a very specific caregiver. We built like a caregiver team, and then kind of did some kung fu on the back end to make that work. So there's some opportunity there as well. So focusing on the next opportunities, we really need to make a decision at Spectrum Health on a single device. We want to eliminate clinical phones. We want to eliminate pagers. We want to have that bi-directional workflow from a smartphone. And we also want to have our apps integrated, right? I think it was mentioned, one of the challenges that we also face is having multiple applications on the phone, having to sign on to each individual one, and having a security policy on 3 or 4 different apps, and getting logged out of one, and it's pretty treacherous territory. So I'm hoping some of these folks can help with that. And then obviously we want to have a real-time contact directory. We're still using SharePoint, which is just awful. Hope there's no Microsoft folks in here. Not anymore. And then the other thing that's kind of this like, it just comes out of nowhere, and this is the conversation with Nurse Call. Our particular vendor wants to be the center of the universe and fix every single problem, including charting and everything, and I'm just trying to sort out where that really fits in. I struggle with Nurse Call, quite frankly. They haven't really evolved, and from a staff assignment perspective, watching a nurse come in and try to manipulate and use Nurse Call, they've come up with some creative processes that I'd love to talk about at another time. So what's coming next, right? I mentioned my watch was telling me to breathe, and I probably didn't do that, and it's still going off, but. So instead of looking at like our inpatient patient population in terms of predictive analytics, I think it's going to rapidly swing to healthy patients, right? And part of the reason for that is things that I call real-time human interfaces, the watch that I'm wearing, the digital assistants with Amazon, with Google Chrome. I mean, these things are picking up so much information from you. It's kind of freaky. They know your eating habits. They know your mood changes. They know your social interactions. Apple's new device is now an FDA-cleared device for monitoring your heart rate. And institutions are going to build health APIs. This is one of the things that we are actually looking at doing, is having this sort of API that pulls in this information that we can use and aggregate. And then on top of that, we talked a little bit, or somebody mentioned artificial intelligence. I think this is the biggest disruptor in this space. This artificial intelligence is going to be personalized. It's personalized artificial intelligence to understand exactly what Jane's habits are, what Jane's interested in, and know if Jane has a deterioration in her health. And it's going to provide Jane feedback in real time through that human interface, which already exists, that, hey, Jane, yesterday you closed your rings and today you didn't. That real-time health index scoring, it's there today. And these things are just taking off. And interestingly, I have on here the advanced population health. This is sort of that same concept that Florence was using in the 1800s. And now we're building our artificial intelligence around those sorts of things. So I think she was on to something. Not only that, but these health service APIs, we're pulling that stuff into our electronic medical record. And not only are we getting real-time feedback to Jane, but Jane's PCP is also getting notified. And that gives us an opportunity to reach out to Jane and say, something's going on here. There's a lot of health problems in your area. Maybe you should come in and get a vaccine or something of that nature. So I flew through this so you guys could go on break. Questions and answers? Yeah. Questions? Any questions? Yes.
Whenever you implemented Muse with the work that you did you look back? I was wondering if you looked at the clinical outcomes at all before and after. So did you actually realize a reduction in rapid response rates or in hospital mortality once you implemented?
So I was going to put some statistics in there, and I didn't. But yes, particularly around the accuracy of the alerts. When we turned on those real-time data feeds, we had some struggles with capturing the appropriate data. The normalization was extremely important because there's variables in there, and the way that Muse is designed, the scoring is so tight to get a number. We're constantly evolving it. But since we've gone to the real-time data feeds, the accuracy of the alert has increased tenfold. And obviously, I feel like that translates to a better patient outcome. But if you want more statistics on that, I can sit down and go over them with you after the session. Thank you. Yes.
First of all, I think your slides are great, and I think we all think you're a great artist. Those are really cool.
Thank you.
Just to piggyback on that, are you able to flip the early warning score algorithm? Besides Muse, are there other early warning score algorithms that you're thinking of implementing or trying out or piloting in some sense?
Yes, yeah, actually we're using the same methods for sepsis notifications. And we're driving that out of the EMR as well. So that kind of sits on top of one of our Epic modules. And those are the two main life critical ones, but there's a number of different informational type messages that are kind of lower priority that we haven't focused on at this point in time. But yeah, sepsis is the other big one that we've implemented and seen some dramatic increases in accuracy as well. Good question, yeah, thanks. I got a question over here. Great.
Jay from Memorial Sloan. A more technical question. So I noticed that all your interfaces are SMTP.
Yes.
We have some similar setups as well, but I guess we're a little bit fearful of being at the mercy of the exchange team. Have you noticed any delays or anything?
Yes. So we try to make that as simple as possible, and in that diagram, I can go back to it. One of the things that I would recommend is not having Exchange do the exchange. And what we did is we have, we're in a hybrid 365 environment, and we're actually using one of our relays, and we built a relay rule to just grab it and send it, so you're not doing anything on the Exchange side. And that, I mean, the delivery mechanisms for that and how quick we're doing that, it'll pay off for you. Good question. Thank you. Any other questions? Got a couple over here, a couple over here. Who's got the mic? Okay.
Hi, Al Valerian from Northwell Health. So have you thought about putting together a folder of all your clinical apps into one location domain to control it by mobile device management software to alleviate the need to have individual people put on their own apps and start using that?
Yes. Yeah. We have a really strong security posture at Spectrum Health, and we do have an MDM. We use AirWatch. But even with that, our security posture dictates that we have another sign-on for these applications. So we have the device sign-on, and then each application has sort of its own profile within MDM. It's super crazy. Yeah. We're working on building a profile with our highest used applications, and we're trying to make it so it's as seamless as possible. I think some of the SSO stuff that these guys are working on is really going to help with that. Building a specific profile around like a clinical mobile device for maybe a hospitalist, or a clinical mobile device for a nurse or a technician.
You know, from a clinical perspective, all the rules are already created. They've all been written, they've all been studied, all been evidence-based. All we need to do as an industry is take those rules and convert them to clinical practice. So draw the catwalk across and say, it's not just sepsis, it's 100 other things that are going on in the background, reading, picking up the data, aggregating it to make sense to send the alert for specific clinical outcomes. And we could do that as an industry, hospitals, et cetera. So it's a lot of opportunity there for you.
Yes, I agree. Yeah, definitely. Got plenty of time for questions. I burned through the presentation, so yeah.
Again, great presentation. I have a question for you. We have Epic also. They have a lot of predictive analytics tools now that they have created that you get 10 for free. Have you utilized looked at any of them to integrate in with your systems?
Yes. So we're fully invested in what we're doing from a predictive analytics perspective, and we're also looking at the cognitive, the cognitive analytics on the analytical side. How that works into the care flows and how that translates down to getting a message to a provider. I think that's where the work is being spent. But yes, I mean, we're looking at it from, there's a gold star program from an Epic perspective, and we're trying to get as far to the 5 stars as we can. And part of that is identifying some of that work, like you had mentioned, particularly outside of sepsis and Muse. We're not there yet, but we're working on it. Good question, challenging question. Any other questions? There's one back here, 2, okay.
Hi.
Hello.
Great presentation, by the way.
Thank you.
I really love your drawings and love to talk about how you did that. But anyway, we also, I'm Patrick McDevitt from Children's Hospital.
Oh yeah, we met.
We chatted about, hi. We also are using SMTP for interface from Epic into our ASCOM platform, and we're looking to move away from ASCOM. We often find that there's queuing going on, and that sometimes the throughput is not fast enough in regards to sending notification to a charge nurse and so forth. Are you considering maybe moving away from SMTP and possibly going with an HL7 interface from Epic? And I know that you're using a WCTP gateway, so I'm not sure whether that can take an HL7 input. But I'm just curious as to next steps, okay?
That'd be a great question for Volt.
Okay, there you go.
You know, Eric is in here somewhere, and we've had conversations about where they're taking their interface. And I think we should all continue to have that conversation on how robust is Volt going to be. Personally, I think Volt should be as robust as possible, so I don't have to think about those sorts of things. Absolutely, queuing is a huge problem, or was a problem, and it has been in the industry for a long time. If I start to see queued messages, I think we're going to back off, quite frankly. I don't want to see queued I don't want to wait for messages to be delivered. In this day and age, we shouldn't have to do that.
Right.
So, yeah, it's a challenge to Volt. I think, you know, let's keep building on that interface. Let's keep building the WCTP, and maybe have a conversation about what to do with an HL7 stream.
Yeah.
You know, yeah, good question. And
Thank you.
I think Eric's writing that down, right? I
Where's
see you
Eric?
over there. Okay. Yeah, with your left hand. Yes.
Yes, I enjoyed your presentation very much. It was very informative. This is back to Muse. One of the things in our institution, Fred, by the way, from Wake Medical, is alarm fatigue.
Yes.
Staff experiences, you know, they get inundated with pagers, they get inundated with calls, you know, with messages. So can you elaborate a little bit on using Muse and what was the staff experience in the environment? And
Sure.
Did it improve? Was it worse?
So we actually have a culture of minimal information as possible. I'm trying to cut this. So an example would be no pass zone for our nurse call solution. We're not sending all of our nurse call alerts to ASCOM phones anymore. Now we have this no pass zone. Anybody that works in our organization walks past the patient room, and if there's a light on, they're going in, right? So I try not to walk by patient rooms anymore. So, but if you're an employee, you know, the patient's first. And that culture, that basis has sort of set the stage for our integration strategy as well. So, you know, we're a 15 hospital organization, and we're sending around 46,000 messages a day, which seems like a lot. But I think, and it also plays into the middleware conversation, we're trying to make it as meaningful as possible, right? Sepsis is something you have to act on immediately. We want to get that alert as quickly as possible. Muse, we need to intervene. Those are life-critical notifications. When I was talking about those different types of information, that one. So when I was talking about these different processes and business rules, we sort of categorized around those and then thought about, well, do we really need to send this message in that way? Does that need to buzz on their hip? You know, the patient's been received a tray of food, you know, for the hospitalist. Do they need to know that? If they do, great. We can build a business rule on that and move that. But yeah, I'm not sure that answered your question exactly. But
Yeah, it did. Thanks.
okay. Okay, one more question? No more questions? I don't know what's going on. All right.
Yeah.
Thanks.
All right. Cheers, Jeff. Great job.